Welcome to the latest edition of the College of American Pathologists CAPcast. I'm Becca Battisfor, content strategist with the CAP. In this episode, our guest host, Dr. Gladell Paner, will be talking with two GI and liver pathologists about how the hepatocellular carcinoma reporting protocol is used in both academic and private practice settings. Before we get into the questions, let's learn more about our guests. Dr. Paner, we'll start with you.
Thank you, Becca. Good day, everyone. My name is Gladell Paner. I'm a GU pathologist practicing at the University of Chicago. And in the past 6 years, I had the pleasure of working for the CAP Cancer Committee and also for the CAP Pathology Reporting Committee. And this year, I busied myself on the education side for CAP, and I'll take this opportunity to promote two of our latest products. One is we have updated the online CAP Gleason course, and this new version will be available on November 11. And the second is we will have a CAP webinar on reporting of prostate cancer. This is a 2-part course. The pre-work activities will be open on November 18, and the actual webinar will be on January 22. So please check these activities out in the CAP education portal. But today, we will be talking about liver cancer reporting.
Great. And Dr. Chopp?
Yeah, my name is Bill Chopp. I'm a pathologist. I've been out in practice for 14 years. I live in the Grand Rapids area of Michigan. I'm part of a Cornwall Health System West. Everybody's kind of integrating these days, so I'm the West component of that area. I'm the medical director of 8 hospitals in that area, and I'm a part of a lovely group of 30 pathologists. And there's 3 of us that see primarily the gastrointestinal component here, and I've been on the CAP Cancer Committee here for I think maybe 5 years. I'm rotating off here in December, so I forgot what the time frame was. And my previous life, I also did the CAP. I wrote the questionnaires for the PIPs.
Great. And Dr. Hart?
Hi, I'm John Hart. I've been at the University of Chicago for the past 33 years. I'm a GI and liver pathologist and currently serve as the vice chair of anatomic pathology. Have had a lifelong interest in liver pathology in particular, and the University of Chicago is a big liver transplant program, so we see a lot of specimens that have hepatocellular carcinoma.
Great. Thank you all for joining. And Dr. Paner, I'll let you take it from here.
Thank you, Becca. So my first question is for Dr. Chopp. We know that Dr. Chopp is one of the primary authors of the CAP protocol for hepatocellular carcinoma, together with Dr. Lawrence Burgard and Dr. Danpat Jain, who incidentally actually was one of our guests in the previous CAPcast. So my question to you, Dr. Chopp, is can you describe to us the background and evolution of the CAP hepatocellular carcinoma reporting protocol?
Yeah, I'll kind of start off with generalities here. I know our audience is, I look at the protocols, like all the protocols, as kind of living and breathing documents. And as many of you know, we kind of try to update these every so often based on new literature. And so I really stand on the backs of many other pathologists that have been doing this for a long period of time. And as we get additional information of qualified data, we try to implement that within the protocol. I came on about 5 years ago. Larry Burgert was there. Great to have people along those lines to kind of help you with this. And what we try to do every time that we do this protocol is review it or not change it based on data. We always try to look at the current data, and we all like to sometimes jump to the newest paper or whatnot. But if we don't have solid data here that's reproducible, we try not to implement that. So quite honestly, sometimes our latest interventions are when we don't change anything at all. We try to look and make sure with that data, we try to look at the SEER data, we try to look at that papers, and if there's nothing going on, which actually the last iteration, I think we put it out in 2023, we really didn't make many changes. I think we had a situation where maybe there was an error in typing or something that we made required that was not supposed to be required. But part of this is what you don't do sometimes is as important as what you do. Because once you do something, it affects obviously national prominence and worldwide prominence as well. So you want to make sure you have the right data. So What we try to do here in this is make sure we vet the data, go through the experts, and then if we don't think there's a change to be needed, then we don't change it. So quite honestly, the last one, we really didn't do too much. We kind of reviewed it, and then we kept it pretty much the same.
Thank you, Dr. Chopp. And I think to add to that is that the updates also for the CAP protocols are pretty much aligned with the updates that we have for the WHO Blue Book and also the AJCC. And if there's any updates on that, then we kind of also do some updating on the CAP protocol. But I don't think there's any updates also recently for that part.
That is correct here. And like you said, we try to time this, and Gladell probably knows this very well. When we know the new WHO is coming out next year, so we kind of hold off on our updates or whatnot to make sure we kind of align. So there's a kind of a big picture thing we try to do on the committee to do this. Do we do it perfect every time? Probably not, but we definitely try to.
Thank you, Dr. Chopp. My next question is for you, Dr. Hart, and this is will be on the practice side of things in the application of the protocol. And my question, Dr. Hart, is what are the benefits of having a CAP hepatocellular carcinoma reporting protocol in our routine pathology practice? And the follow-up question for that is, what are your clinicians' response to having this synoptic reporting?
Synoptic reporting is key. I don't think in this era we can live without it. Tumor board follows precisely the synoptic reporting parameters, and the oncologists and the surgeons want to hear each of those items ticked off and make sure that it just provides a very consistent approach that the oncologists are very comfortable with, the surgeons are comfortable with, and allows clinical trial construction and understanding data from these clinical trials as they come up. So can't live without these. Of course, as a practicing pathologist, you always have little things about each of the protocols that you wish were different or that you recognize is a problematic area. But standardization is just an absolute necessity. So thank goodness for these protocols.
Thank you, Dr. Hart. Those are excellent points. And also, I may add to that is that, this protocols assures us that the required elements that is needed for inspection are automatically there already. And just to add to that, and I work together with Dr. Hart, and here we are using the electronic reporting protocol. So once we sign out the reports, all those required elements are automatically checked. So my next question, I'm going to delve into the elements or the content of the hepatocellular reporting protocol. So this question is for both of you. And I would start with Dr. Chopp. Dr. Chopp, tell us about the histologic subtypes of hepatocellular carcinoma, and what are the subtypes that are relatively challenging to diagnose?
Okay, I can take that in kind of two paths here. I think the ones that look like normal liver is a bigger and the ones that don't look like liver are probably the biggest categories here. But I'll step back a little bit here. We're looking at the protocol here. Right now, I think we only have 4 subtypes that we actually classify, and then we have a area underneath it where we have a situation where we allow the pathologist to put whatever subtype. Currently, right now, we just have traditional hepatocellular carcinoma, fibrolamellar, serous, and clear cell type. Obviously, there's other ones recognized by the WHO that aren't on there. Ones that are recognized by the WHO that I have a hard time with is steatohepatitic. I have seen many times where myself or others, when you first look at that liver biopsy or whatever you get, you look at it, you're like, is this just steatohepatitis in the background? And I've seen a lot of my partners and myself, when the first glance, you kind of look at that, and then you kind of have to go down that pathway is this lesional tissue? And if it is this possibly a steatohepatitic hepatocellular carcinoma? As my bad joke I said initially before, also the other ones are the ones that look very normal, and there's maybe subtleties in that core biopsy that you look for, where you also ask yourself, is this normal liver? Then you start going on to look into the plates, and you get reticulin and do other things that maybe help you classify it. But I think that's the other big pathway I kind of fall down as well. And then there's the classification of hey, this looks like it's a malignant something or another. Is this a poorly differentiated or undifferentiated form of the hepatocellular? And then you use your stains to kind of classify that way. So as I said initially, I think it's the ones that maybe look like normal liver or somewhat abnormal liver that are hard to classify, and the ones that you have a hard time telling it's actually a liver biopsy at all.
Thank you, Dr. Chopp. I'm going to loop the same question to Dr. Hart. And Dr. Hart has a big liver consultation service. And so the same question to you, Dr. Hart, regarding the histologic subtypes, and also what subtypes do you think are challenging to diagnosis? And of course, we have, as Dr. Chopp mentioned, we also have to consider the specimen, not only innate to the tumor, but also especially in a biopsy specimen.
I agree with everything that Dr. Chopp already mentioned. I do feel like we're behind. I'm envious of our GU colleagues with all of their beautiful subtypes of renal cell carcinoma, each with its molecular pathway, its characteristic immunohistochemical stains, and its clinical impact. I do feel like hepatocellular carcinoma is slowly moving in that direction. And it's going to be, and I hope in the next iteration of the CAP synoptic report form, it will capture some of these new emerging subtypes. Like the steatohepatitic subtype, I think that is deserving of separate recognition and should be coded or captured in our synoptic report. Another one that I think is very important is the macrotrabecular massive subtype of HCC. It has a real clinical relevance. It has a much higher rate of recurrence after RFA or after resection, because it is often multifocal and it has a high incidence of vascular invasion. And there are a couple others that are emerging as well. I know this obviously has to be data-driven. There has to be good data for Dr. Chopp and Burgart and Jane to look at that justify inclusion. But I think that hopefully in the next iteration, we'll have those additional subtypes included. There's a wonderful paper by Mike Formanson talking specifically about subtypes of hepatocellular carcinoma and where it makes sense. Obviously, it doesn't make sense to recognize a subtype if it doesn't really have any molecular basis, characteristic mutation or fusion, and also some clinical impact. If it's no different than ordinary hepatocellular carcinoma, then really is it of value to separate out a subtype? But for those subtypes that do satisfy those criteria, I hope that we can move to recognizing them in our CAP protocols.
Thank you, Dr. Hart. So the way I understand is that subtyping is pretty much on the histologic side of things.
Yes, right now it's on the histologic side of things, and but molecular is becoming increasingly important as well, and particularly in a non-cirrhotic background. And I would encourage all the listeners to remember that important point when you're talking about liver tumors, is that the differential diagnosis is just dramatically different when you have a cirrhotic background versus a non-cirrhotic background. In a non-cirrhotic background, you certainly have to think about benign hepatocellular lesions like focal nodular hyperplasia and adenoma. Dr. Chopp was referencing that, but also metastatic tumors that can very closely resemble hepatocellular carcinoma, and we don't want to make that error. In a cirrhotic background, it's very different. You're really, if you think you have a malignant tumor, you're really limited to hepatocellular carcinoma and cholangiocarcinoma.
Thank you, Dr. Hart. And I would have a follow-up question here for you, and this is about molecular testing. And my question is that, what are the usual reasons for ordering molecular testings for hepatocellular carcinoma in your practice? Do you order molecular tests for diagnostic purpose or for predictive markers as a response to therapy?
Where we use it sometimes is in the distinction in a difficult case, particularly in a needle biopsy sample, between hepatocellular and adenoma and hepatocellular carcinoma. If you have a TERT promoter mutation, that is strong evidence that you're dealing with hepatocellular carcinoma. that might be extremely well differentiated and look very much like a hepatocellular adenoma. So there are selected circumstances. It's much more important in cholangiocarcinoma that we won't be discussing during this broadcast, but there the oncologists often ask for next-gen sequencing, whereas in hepatocellular carcinoma, not as often.
Thank you, Dr. Hart. And I'm going to loop on the same question to you, Dr. Chopp. So in the private practice setting in particular, in terms of molecular testing for hepatocellular carcinoma, for diagnostic purpose, for predictive reason as well, can you comment on that?
Yeah, I would say even though we have a great molecular lab, I haven't utilized it much in the community practice setting. If I have questions about something, I think but for myself, it's always phone a friend. I think in the pathology community, within my own walls and outside the walls, if I don't know what it is, I haven't found it to help me too much. And I found, if I find a colleague at another institution to give me another eye on it, I've always found that to help a little bit more right now.
I'll add that sometimes you have a very poorly differentiated tumor, and you're considering both cholangiocarcinoma and HCC, and that might also be a circumstance where molecular could be of value because the molecular profile is somewhat different in those two choices. So there's another opportunity in selected cases where molecular can be of value.
So I'm going to move on to another element here, and this is for our audience for clarification of this particular element between multifocality and satellite lesions. So I'm going to ask this question to you, Dr. Chopp. So the question is, describe to us the difference between tumor multifocality and satellite lesions, and what is the clinical significance of these findings?
So looking at this with satellitosis, currently for the checklist here, it's a non-required element. There's some different definitions depending on where you kind of look at this at, but based on the International Collaboration on Cancer Reporting, it is recommended that if there's what you see as a larger lesion, if there are smaller lesions, 2 centimeters or less from that larger lesion and are smaller, then they can call that satellitosis. People are believed that's due to the kind of like venule, kind of little metastasis to that area. Like I said, that is one classification and how people use it. That is what we have kind of used in the CAP cancer checklist template from there. With tumor multifocality here, I think I look at this, and I'd like to see what Dr. Hart thinks. I don't know if there's always great definitions for all the people trying to define that away from there, but I would then define it a further distance away from that than those satellite lesions that are less than 2 centimeters away. You can look at this data, and I think if you look at some of these situations of when people do molecular data comparing some of these things, and I think there's been a mixed bag trying to tell the difference between multifocality or intrahepatic metastasis in some of these lesions. I think some papers support it and some don't. I don't know if it's really helped us kind of clarify the situation.
Thank you, Dr. Chopp. Dr. Hart, any comments?
Yeah, no, I agree completely, and I use the CAP's synoptic report definition for satellite lesions. We get a lot of native livers, and the larger the resection is, the more likely, obviously, you're going to find additional tumors. We sample very carefully. We slice our native livers very thinly, and we find lots of dysplastic nodules and small hepatocellular carcinomas at a distance, and we regard those as separate tumors, multiple tumors. Even if it is possible that they represent intravascular spread of a primary tumor, we report them out as separate tumors. And it's amazing the number of tumors that we find in these native livers that are below the limit of detection for our radiology colleagues. And so we often have cases where we use the M designation for multiple tumors. The other area that becomes a little bit difficult to apply is in a tumor that's been treated either by tear or by radiofrequency ablation. You get a very large irregular kill zone where the parenchyma has been extinguished due to the treatment. And then you have little nodules of residual viable tumor. And then again, you get into a definitional issue. Are these independent tumors? Are these satellite tumors? It can be a little bit tricky, but we just apply the criteria that we have in a standardized fashion using the CAP guidelines. That's how we approach those cases.
Thank you, Dr. Hart and Dr. Chopp. Dr. Hart, you mentioned you referred to the staging using the M descriptor in multiple primary tumors. Just to clarify, when you have a satellite lesion, would that count as multiple tumors? Would that upstage?
No, we don't count that. That's just a satellite tumor. Yeah, if it's less than 2 centimeters. So
okay, great.
Single tumor, yeah. And we just note the presence of satellite nodules. It actually is important. The size of the lesion is very important, and the number of lesions is very important because beyond the CAP protocol reporting for cancer treatment, there's also the liver transplant requirements. Patients either are within the criteria for liver transplantation or outside of it. And so if you have the number of tumors applies in that situation. So we need to have a very accurate count of the number of tumors that are present so that the hepatologist can report back to the liver transplant societies about their adherence to those transplant guidelines outside of the setting of the oncologist reporting and treating the patient for cancer.
Thank you, Dr. Hart. And so my next question is actually related to your answer earlier. So this is about the use of the CAP protocols or elements outside of what is required in the current HCC protocol. So my question to you, Dr. Hart, is in your practice, what additional pathology parameters, including experimental or research elements, that you include in your pathology report for hepatocellular carcinoma, if any, outside of what is required by CAP?
There actually isn't a lot that we add as a comment. We spend a lot of time, of course, describing the background liver. It has a lot of impact, particularly in the liver transplant, but also in resections for the patients going forward. So I know that you get a resection for cancer, you are honing in on the cancer, but don't forget the background liver. Talk about the presence of steatohepatitis or steatosis. Treatment effects, chemotherapy-induced veno-occlusive disease or chemotherapy-induced steatohepatitis, that needs to be mentioned. The degree of steatosis turns out to be a really important parameter that should always be included in the report for the specimen. And it has this impact. The more steatotic the liver is, the lower its regenerative capacity. And so if they're considering another large liver resection, they may not be able to do that if the surrounding parenchyma is highly steatotic. So it's really important for the pathologist to mention that. They may decide, okay, this patient, unless they lose weight or get their diabetes under control, reduce their steatosis, isn't going to be a resection candidate, but instead might have to have radiofrequency ablation or TARE therapy because you're removing a large volume of tumor. You don't want to tip the patient into liver failure because their non-tumor parenchyma is diseased.
Thank you, Dr. Hart. It is interesting. Also do the same approach for our resection of kidney cancer. We also make a comment on the status of the non-neoplastic renal parenchyma. That's very important. And actually some of the renal cell carcinoma potentially have favorable prognosis. And actually what the findings on that non-neoplastic kidney will be much more important actually than the tumor. I just have a follow-up question for that, Dr. Hart. For us in GU, we usually don't comment on the non-neoplastic kidney in the biopsy setting. If we have a biopsy for a mass lesion, how about in liver biopsy when you have a tumor and then you have a non-neoplastic parenchyma? Do you put a comment on that?
Yes, we do. We always do. We try, recognizing with a disclaimer that says that the amount of surrounding parenchyma is insufficient for evaluation. We often say that. But if there is sufficient and we think we're away, it's not just mass effect. One of our most common comments are the surrounding parenchyma exhibits features consistent with mass effect. But if we do have a sizable amount, even in a biopsy, we'll talk about the degree of fibrosis and the degree of steatosis, getting a little away from the hepatocellular carcinoma arena. For metastatic colon cancer, those patients will all be treated with chemotherapy. And so veno-occlusive disease and steatohepatitis related to the chemotherapy given routinely for metastatic colon cancer, you're going to want to report on those two elements in every biopsy.
So what is on the horizon for the CAP protocols of hepatocellular carcinoma that may be considered in the near term?
Well, I think Dr. Hart kind of gave you a preview of some of the things that we've been kind of looking at. Obviously, as you alluded to, a lot of it's by histologic type right now. Things are moving past that. We have some great work by Dr. Hart and Torbenson and Sanjay Kekar and all that wonderful group there that's kind of given us a little bit more that we could actually apply to this. And as you said, as I alluded to before, we want to find ones that are clinically meaningful, not just to have a descriptive thing, but things that mean something to the patient. So I think Dr. Hart kind of alluded to a couple there. And I think the next time we come through, I wouldn't be surprised if a couple of those are in there.
Thank you, Dr. Chopp. And I'm going to loop the same question to you, Dr. Hart. Do you think there's any additional parameters that they're in the horizon?
Yes, I think the subtypes are the main thing. We're going to have some molecularly defined subtypes of hepatocellular carcinoma down the road that will need to be included when there's sufficient data for the powers to be to feel that they're absolutely necessary. There's one thing that I'm hoping for in the next, and that is to get away from the microvascular invasion, upstaging the patient. This puts an incredible amount of pressure on the pathologist. I think we're all practicing pathologists, and we know how difficult it is to reproducibly recognize microvascular invasion. And it's something that when I'm looking with our fellows, they're trying to make a decision, is this, because it does upstage the patient, whether microvascular invasion is important or not, to recognize is really difficult. So I'm hoping that maybe that can be dropped. Certainly macro invasion of a vessel is obviously very important, but it becomes an issue also in these treated cases and how much sampling that you're going to do in the area. And I always feel a little uneasy when we have a large area of killed parenchyma, a lot of parenchymal extinction, trying to submit all of that tissue looking for things like microvascular invasion can be quite difficult. So
thank you, Dr. Hart. I'd just like to go back to Dr. Chopp, just in case you have additional comments on that.
No, I like to say I think there's a lot to that. All of us have that consternation, whatever system you look at, if it's in the endometrium or if it's the thyroid, looking in the capsule for the vascular invasion, we could all ask ourselves, there's pathology is sometimes not a precise science in some of that lymphovascular stuff. And there's always papers that try to give you a kind of a hold, but I do think you make a good point. When something's not very reproducible, sometimes we have some criteria. Is that something we can hang our hat on? And that's what I want to bring up, how these protocols are living and breathing documents, and they change over time. And with that, as people give suggestions like Dr. Hart, and for the pathology community that don't know, you can submit your questions about things that you have questions about and to the committee, and we look at those very seriously. And things like that are things we look at, try to review the data, and see if we can come up with changes that are better based on that newer literature. Like I said, we are a brethren. We're a community here working together, trying to do the best we can. And we have experts along the lines with Dr. Hart and crew, but we also have general community pathologists that are going through things every day and that send us questions just like this that we look at and try to answer. And sometimes we scratch our head. It's like, why have we done this for the last 10 years and made people do this? Does it really make sense anymore? And with the newer data. So as I say that, I think the biggest thing is we're a community. We want the experts that are doing the research, but we also need the community people that are practicing day to day saying, hey, is this really something that we need to do? And is this something that's really bringing value? Because if it's not bringing value or reproducibility, are we really doing anybody any benefit?
Yeah. Well, here in the ACC, it's T1 versus T2 can
Yep.
be based solely on finding a micro. I don't know if any other CAP protocol has a microvascular invasion changing the T stage that dramatically, but anyhow, just something I need to get off my chest.
No, hey, I think that's well taken. And these are the type of discourses I think people have.
Yeah.
We want to make things better. And I think all of us want to make things better. And like I said, sometimes you look at something, you're like, why have we made people do this? And what's the actual literature behind this?
Right.
And that's what we want to look. Let's go to that primary literature that made somebody do that to see is it really there or not. We try to base a lot of the things on the HACC, but let's look at their primary literature of why they place in there as well. Like I said, living and breathing documents, that always can be improved.
Thank you, Dr. Chopp. Yeah, so lymphovascular invasion actually is also being looked at into the staging of testicular cancer. So there's something similar there for testicular cancer and also liver cancer. So unfortunately, that's all the time that we have. So I would like to thank Dr. Chopp, Dr. Hart, for your expertise and insights regarding the diagnosis and reporting of liver cancer. And I will go back to you, Becca.
Thank you, Dr. Paner, for leading the conversation. And I'd also like to thank Dr. Chopp and Dr. Hart for your insights on this topic. And I want to thank you all for listening to this CAPcast. You can find the CAP's Hepatocellular Carcinoma protocol, along with over 100 other protocols designed to assist pathologists in case reporting, on our website. If you have questions or comments about any of the protocols, please email cancerprotocols@cap.org. And for more information about the CAP, visit cap.org.